Hello everyone. Thank you for joining this virtual CME. I'm Dr. Alex Tan and I'll be presenting on community-acquired pneumonia. Community-acquired pneumonia is a leading cause of mortality and morbidity worldwide. The clinical presentation of CAP varies, ranging from the mild form characterized by fever and productive cough to severe pneumonia characterized by respiratory distress and sepsis. And because of its wide spectrum of associated clinical features, pneumonia is part of a differential diagnosis of almost all respiratory illnesses. Community-acquired pneumonia is an acute infection of the pulmonary parenchyma acquired outside of the hospital. And if it's acquired in the hospital, it is known as nosocomial acquired pneumonia, which is subcategorized into hospital-acquired pneumonia, HAP, or ventilator-acquired pneumonia, VAP. HCAP, also known as healthcare-associated pneumonia, is no longer in play as according to the IDSA ATS consensus guideline in 2019. HCAP is a term used to identify patients at risk for infection with multi-drug resistance pathogens. However, this categorization might be overly sensitive and leading to increased and inappropriately broad antibiotic use and is thus retired. Now let's look into the statistics on cause of death in Malaysia 2018. Pneumonia is the second leading cause of death in Malaysia in 2017 with a percentage of 12.7%. Now, if looking into the age group, you can see that in population of age 60 years and above, pneumonia is the leading cause of 16.4%. Coming into more recent data in Malaysia, in year 2018 and 2019, pneumonia is still the second leading cause of death with 11.8% in 2018 and 12.2% in 2019. Now, even though that later on in Malaysia, across all age group, pneumonia is no longer the leading cause of death, but however, it is still undeniable that pneumonia placed number 2 in the leading cause of death in Malaysia. What are the risk factors of getting a pneumonia infection? Number 1 being elder age. The older a person, the higher the risk of that person getting infection. We look into a paper from 2017 looking at the impact of age and the incidence of patients hospitalized diagnosed with pneumonia. As you can see, from 55 years old and above, the number of pneumonia infection actually doubled and it increased more in the elderly age. And secondly, of course, chronic comorbidity, smoking and alcohol overuse. COPD being the leading risk of patients getting a pneumonia, subsequently with chronic heart disease, stroke, diabetes, active smokers and obesity as well. Viral respiratory tract infection, especially in the current COVID-19 pandemic situations, impact airway protection, especially in stroke patient with neuromuscular disease who can't properly swallow food and having higher risk of aspiration. Social and lifestyle factors such as patients living in a poor hygiene condition, work-related exposure, and having a risk of lung injury and chronic lung disease. Most of the pneumonias are due to bacterial pathogens or respiratory viruses infection. Now, Streptococcus pneumonia still plays first place in among the most common cause of bacterial pathogens infecting patients, even though with the widespread use of pneumococcal vaccine nowadays. And we also have Pneumophilus influenza, Mycoplasma pneumoniae, Staphylococcus aureus, Legionella species, Chlamydia pneumoniae, Moracella catarrhalis. Respiratory viruses such as influenza and parainfluenza viruses are still very commonly seen, and as of what we are facing now, the pandemic of coronavirus infection, uh, be aware that coronavirus doesn't just include COVID-19, but MERS-CoV, SARS as well. And of course, as a doctor, we all know how to treat pneumonia, but with the help of certain guidelines, of course, it will give us a better idea in terms of how to treat, when to treat, and how long to treat, and also including the further treatment plan in pneumonia. So ATS IDSA has actually a consensus guideline in treatment of community-acquired pneumonia in adults in 2007, and in 2019 they have released an official clinical practice guideline as adjusted compared to CPG release in 2007. It includes 23 pages with 90 main questions answered. Diagnosis of pneumonia comprise of three major parts: the clinical, the radiological, and microbiological. Clinical diagnosis of pneumonia will need to look into the pulmonary component and also the systemic component. Pulmonary components include symptoms and signs like cough, either productive or non-productive, dyspnea, pleuritic chest pain, and downers on percussion with or vocal fermenters, crepitus on the auscultation with a reduced air entry or hypoxia, while systemically patient might complain of fever, myalgia, arthralgia, malaise, loss of weight, loss of appetite. In severe cases, you might have altered mental status, hypotension, and other organ dysfunctions. Radiological imaging is a crucial part in the diagnosis of pneumonia, and chest X-ray is still the mainstay and the easiest way of diagnosing pneumonia. On the chest X-ray, you can see consolidation, cavitation, infiltrates, ground glass changes, or as common as perihilar haziness. But bear in mind that you will need a good quality chest X-ray with a good inspiration, good penetration to support the diagnosis. Otherwise, you might have artifacts that falsely point you towards pneumonia. Ultrasound is a good and very sensitive method to pick up diagnosis of pneumonia. You can detect consolidation, parapneumonic effusion, empyema, and it's definitely easy and sensitive if you have a proper setting of it, be it in emergency department or in GP setting. And CT thorax, of course, is a good method also to help in the diagnosis of pneumonia. But I would suppose that in our setting, CT thorax will be a better choice or used as a choice to help to exclude the alternative diagnosis such as abscess formation, TB, or malignancy. And of course, because we are going to treat pneumonia with antibiotics, we definitely need microbiological aid in helping to guide us in our treatment plan. Respiratory secretion culture is mandatory to be sent before we start the antibiotic, but bear in mind that up to 50% of patients might have a negative sputum culture in pneumonia. Not to mention that a lot of patients can't produce a good quality sputum for testing, and in GP clinic or certain hospital setting, they might not be able to provide culture testing. And a lot of patients before they come to hospital, they actually have visited GP or clinic and might have been given courses of antibiotic, and thus reducing the yield of positive culture even lower. And secondly, we talk about blood culture. In non-severe pneumonia, blood culture yield is as low as 2 to 9%. So based on this IDSA ATS 2019 guideline actually says that in outpatient setting, no cultures are recommended to be taken. and it's only taken in severe pneumonia, especially in the intubated ones, and those who are temporarily covered for MRSA or Pseudomonas aeruginosa infection with the history of previous MRSA Pseudomonas infection or previously hospitalized and received parenteral antibiotics in the last 90 days. Now, what is considered as severe pneumonia? Here are some criteria to help us out. One major criteria or three or more minor criteria. Major criteria include septic shock with need for vasopressors or respiratory failure requiring mechanical ventilations. Minor criteria are respiratory rate of more or equal to 30 breaths per minute, PaO2 over FiO2 ratio of less than 250, multilobar infiltrates, altered mental status, uremia, leukopenia of total white less than 4,000, thrombocytopenia of platelet less than 100,000, hypothermia of less than 36 degrees Celsius, or hypotension that require aggressive fluid resuscitations. Other than cultures, we can also send urinary antigen testing for pneumococcal antigen or Legionella antigen, lower respiratory tract secretion for Legionella culture, Legionella NAAT, serology tests such as for Mycoplasma or melioidosis, and all these are recommended in the IDSA ATS guideline for severe pneumonia, but taking into the consideration of epidemiological factors, especially during outbreaks like Legionella outbreaks or melioidosis outbreak in Malaysia. Pneumonias usually come with clinical and laboratory findings limited to the lungs, and the typical CAP are usually infected by bacterial pathogens which are classically responding well to beta-lactam antibiotic therapy because they have a cell wall amenable to beta-lactam disruption, and the chest X-ray will usually show lobar or segmental homogeneous opacity in over 80% of typical bacterial pneumonias. However, in another subgroup of pneumonia, which are called as atypical pneumonia, they are the systemic infectious disease with a pulmonary component. And in contrast to the typical pneumonia, most of these atypical pathogens do not have a bacterial cell wall. Some are intracellular, for example, Legionella, and some are paracellular, like your Mycoplasma pneumoniae. And this finding can also be seen in nearly half of the cases of atypical infection, but diffuse, patchy, or ground glass shadow are more commonly observed in the chest X-ray. Some common causes of atypical pneumonia are Mycoplasma pneumoniae, chlamydophilia, respiratory tract viruses such as your influenza, adenovirus, RSV, parainfluenza viruses, and of course, as of now, COVID-19. Bacteria such as Legionella, funguses, other viral agents such as varicella zoster, measles, EBV, CMV, and rickettsia. And of course, we talk about sterile pneumonia or pneumonitis due to aspirations. This is the typical chest X-ray of atypical pneumonia. You can see ground glass opacity, infiltrative changes as well. Now, in the IDSA ATS 2019 guideline, there are few questions that are discussed on should the clinical judgment with a clinical prediction rule for prognosis versus clinical judgment alone be used to determine whether or not a patient to be treated outpatient, inpatient, or in ICU setting. And in addition to clinical judgment, it is recommended that the treating doctor should use a validated clinical prediction rule for prognosis and planning out the treatment plan. These are the two prediction tool that is recommended, namely Pneumonia Severity Index and CURB 65. And PSI is actually preferred over CURB 65 score because PSI was actually found in multi-centered clustered randomized trials that it can safely increases the proportion of patients who can be treated in the outpatient setting. Namely, it can identify a larger proportion of patients as low risk and actually has a higher discriminative power in predicting mortality. Now we look into both prediction too. Pneumonia Severity Index has four major components: demographics, comorbidities, physical examination and vital signs, and laboratory imaging. And all the points add up, we can divide patients into 5 risk class. With class 3 and below, 90 points and below are safe to be treated as outpatient. Class 4 treated inpatient, and class 5 to be treated in ICU setting. And in CURB 65, it is a simpler score system and can be easily used in an emergency setting or in a clinic setting. And they classify patients into 3 groups: Group 1 as outpatient, Group 2 inpatient treatment, and Group 3 in ICU treatment. Now, looking back at Pneumonia Severity Index demographically, age is actually 1 point per year, and this is why PSI may underestimate illness severity among the younger patient, and it might actually also oversimplify on how clinicians interpret continuous variables. Now, we have two useful tools to help us in the diagnosis and also prognosticating patients' outcome. But clinical severity is not the only consideration in determining the need for hospital admission. We also have to look into the medical and also the psychosocial status of the patient on whether or not they are safe to be treated as outpatient, such as, for example, unable to tolerate orally, patients staying very far away from hospital, so in case of their deterioration, they might not be able to come to hospital quick, or others such as history of substance abuse, cognitive impairment, severe comorbid illnesses, and impaired functional status. Looking into treatment of pneumonia, as I have mentioned just now, we have two scoring systems and different risk groups to help us in determining where to send them, how to treat them. PSI score risk group of 3 or below, or CURB score of group 1 can be treated as outpatient. Inpatient treatment includes patients who are in PSI risk group 4 and above, CURB score 2 and 3, or PSI score group 3 of 71 to 90 points, or CURB 65 score 1 point, with medical and also psychosocial contraindications to outpatient therapy, as I have explained just now. PSI risk group 5 or CURB 65 group 3 should be treated in ICU setting. And based on this, we will further look into the treatment plan, antibiotic choice, and of course later on the discharge criteria and de-escalation to oral treatment. Now, the concerns in treatment of pneumonia is, of course, number one, to treat or not to treat. And if we are to treat, what to treat as? Antibiotics, antifungal, antiviral, or just wait and see. And number two, of course, choices of antibiotic with what coverage. Duration of antibiotics is of course important, and later on to switch from IV to oral antibiotic. And we need to take into considerations of local antibiograms in the terms of resistance and which are the more common bugs around our hospital compared to other hospitals, local versus international antibiotic guidelines, and of course comorbidities of patients, which includes chronic heart, lung, liver, or renal diseases, diabetes mellitus, alcoholism, malignancy, or asplenia as immunocompromised. Now, this is an example of local antibiogram taken out from National Antibiotic Guideline 2019. Streptococcus pneumonia is still the commonest bacterial pathogen in causing pneumonia worldwide, including Malaysia. And as you can see, from 2013 to 2018, this bug actually shows high resistance against erythromycin and Bactrim. Uh, and this is also one of the reasons why erythromycin is now less commonly prescribed as outpatient therapy, nor is it recommended. So we compare National Antibiotic Guideline of Malaysia 2019 with IDSA ATS 2019 guideline. In an outpatient setting, Malaysia guideline actually preferred amoxicillin 500 mg orally, TDS 5 to 7 days, and alternatively you can go with augmentin or doxycycline. While IDSA ATS 2019 guideline actually look into two patients with risk or comorbids. Patient without risk or comorbids, we suggest amoxicillin 1 gram TDS or doxycycline or macrolides if the local pneumococcal resistance is less than 25%. And the antibiotic of choice are azithromycin, clarithromycin, or clarithromycin ER. But in patients with comorbids, you can actually go for monotherapy with respiratory phonoquinolones, such as levofloxacin, moxifloxacin, or gemifloxacin, or combined therapy with augmentin or a oral cephalosporin plus a macrolide or doxycycline. And in the inpatient setting, National Antibiotic Guideline 2019 actually have a simple recommendation list. It doesn't look into the severity and the risk factors, and the suggestion is preferred amoxicillin clavulanic acid plus an azithromycin, or alternatively you can go for ceftriaxone plus azithromycin. And if the patient has a confirmed penicillin allergy, you can choose levofloxacin IV or oral route for 5 to 7 days. By the IDSA ATS 2019 guideline, we subdivide patients into severe, non-severe, with or without risk factors. Risk factors being patient has previous respiratory isolation or MRSA, Pseudomonas aeruginosa, or recent hospitalization and receive of parenteral antibiotic in the last 90 days. So in an unsevere with no risk factor group, you can actually go for monotherapy such as with respiratory phonoquinolone, or combined therapy with beta-lactam plus a macrolide. And risk factors such as MRSA, Pseudomonas aeruginosa isolation, or with recent hospitalization, we will increase the antibiotic coverage, but of course before that we should obtain cultures so that it will allow for later on de-escalation or to confirm for continuation of the treatment. And then in severe case, severe with no risk factors, IDSA ATS guidelines suggest that we either can choose from 1 beta-lactam plus macrolides or beta-lactam plus fluoroquinolones. And of course, the same coverage of MRSA or Pseudomonas go for patients with risk factors, with the culture to be taken prior to the initiation of the treatment. And of course, not to forget that if you suspect a patient is infected with viral infection, such as influenza, you might want to start the patient with oseltamivir or Tamiflu 75 mg BD for 5 days, or with renal adjustment dose. Varicella zoster with acyclovir 10 mg per kilo IV TDS for 7 days. And of course, prior to that, you should obtain a throat swab or nasopharyngeal swab for SARI. And in our current situation, of course, COVID-19 infection is a diagnosis to exclude out before anything else. So why does antibiotic duration matters? An adequate treatment with antibiotics in pneumonia is crucial to make sure the infection is cured, while reducing the antimicrobial resistance reduces the risk of Clostridium difficile infection, reduces risk of antimicrobial related organ toxicity, and reduces hospital costs and length of stay, and at the same time improves drug compliance. And in a nutshell, less is more. The 2007 IDSA-ATS guideline on the management of community-acquired pneumonia in adults states that should a patient be initiated an antibiotic, they should be afebrile in 48 to 72 hours and clinically stable, and they should be treated for a minimum of 5 days of antibiotic. A longer duration of therapy might be needed if the initial therapy is not active against the subsequently identified pathogen, or there is a loculated fluid collection such as empyema, CNS abscess, or complicated with extrapulmonary infections such as splenic abscess, liver abscess, etc. Now, a lot of studies has been carrying out to decide or determine what is the optimum durations of antibiotic treatment. We look into this paper, which is done in 2006, effectiveness of discontinuing antibiotics treatment after 3 days versus 8 days in mild to moderate or severe community-acquired pneumonia. And result come back as clinically cured at 10 days and 28 days in both group are have no significant differences. However, the adverse event is significantly lesser in 3 days group compared to the 8 days group. Another paper showing that the duration of antibiotic treatment in community-acquired pneumonia randomized at day 5 to stopping antibiotic if met the clinical stability versus physician discretion. It shows that 30 days rates of clinical success was significantly higher for shorter course versus standard therapy, and the readmission rate was actually lower for shorter course regimen as well. Now we talk about switching of antibiotic from IV to oral route. But I should mention that switching the antibiotic from IV to oral doesn't really reduce or help in the AMS program, but it does reduce the risk of patient getting a thrombophlebitis or getting a bloodstream infection from catheterization or granular insertion, thereby reducing the chance of needing more high-end antibiotic, and of course reducing the length of hospital stay and cost. So these are the two guidelines that we can refer to: the National Antimicrobial Guideline 2019, and of course the Protocol on AMS Program in Healthcare Facility in 2014. Here are the list of example of antibiotic that can be switched from IV to oral route. Either it's sequential or switch therapy from IV directly to oral, such as azithromycin, cefuroxime, ciprofloxacin, doxycycline, levofloxacin, linezolid, metronidazole, Bactrim, and or step down therapy with the oral equivalent, such as your ampicillin to your amoxicillin, Unicin on Augmentin, and etc. And of course, when we talk about oral antibiotic, we talk about the bioavailability of both IV and oral formulations. Here is the example of few antibiotics that have high oral bioavailability and definitely will benefit patient more if we switch them to oral therapy earlier, such as ciprofloxacin, clindamycin, doxycycline, fluconazole, metronidazole, moxifloxacin, and Bactrim. Bear in mind that azithromycin have less than 50% of oral bioavailability, but then it is well distributed into the tissues, so efficacy is still there. So how do we decide when to switch a patient from IV to oral route of antibiotic administration? When you have a patient started on IV antibiotic, you should be reassessing them after 48 to 72 hours of treatment. If the patient still have poor oral intake or unable to tolerate orally, or they have continuing of sepsis with a positive SIRS criteria or deteriorating clinically, or they have special indications such that requires continuous IV antibiotics, such as infective endocarditis, CNS infection, orbitocellulitis, osteomyelitis, melioidosis, or deep-seated abscess, or there is no oral formulation available for that particular antibiotic, then you should continue to use IV antibiotic and continue with subsequent reassessment to decide whether or not to continue or to stop. If all of the above are not indicated, then you can actually safely switch them to oral therapy. And last but not least, we talk about vaccination, especially pneumococcal vaccination, influenza vaccination, and hopefully in the very near future, the COVID-19 vaccination. Why is vaccination important? Now, this is the data coming from a retrospective cohort study from 3 large longitudinal US healthcare databases of medical and outpatient pharmacy claims from 2007 to 2010. As you can see, chronic lung disease, asthma, neuromuscular disorder, or seizure disorder, these patients have a high risk of getting a pneumococcal infection. And as the age advances, the risk of them contracting the infection is even higher. And bear in mind that if most of the time they won't just suffer from one morbidity, but they might have 2 or even 3 or more comorbids such as heart failure with chronic lung disease and diabetes, high blood pressure, and of course chronic lung smoking. So based on this, CDC has actually released multiple guidelines and recommendations on pneumococcal vaccination, latest one being in year 2019, and it recommends that in all persons of age of 65 and above, they should receive a pneumococcal vaccination. And for other patients with specific underlying medical conditions or in immunocompromised statuses, as young as 19 years old, they should be receiving pneumococcal vaccination. And last but not least, we talk about influenza vaccine. These are the groups of people with higher risk for serious influenza complication. Worth mentioning is that influenza infection itself actually seldom cause mortality, but patients usually die of complication from influenza infection. They are the children of less than 5 years old, but especially less than 2 years old, adults of more than 65 years old, pregnant lady or up to 2 weeks postpartum, residents at nursing homes and long-term care facilities, people with medical conditions including chronic lung disease, asthma, heart disease, blood disorder, immunocompromised status such as HIV infection, malignancy, or patient receiving chemotherapy, immunosuppressants, or immunomodulators, children less than 19 years old with long-term aspirin therapy, or people who are extremely obese with BMI of more than 40. These are the people with higher risk, but however, routine annual influenza vaccination of all persons aged more than 6 months old who do not have any contraindications for vaccinations are continues to be recommended based on CDC guideline latest release in August 2020. So these are a few more extra points that are actually pointed out in the IDSA ATS 2019 guidelines as compared to 2007. Use of procalcitonin and corticosteroids are generally not recommended in treatment of CAP. However, we might consider corticosteroids usage in a patient with refractory septic shock. Use of healthcare-associated pneumonia term is no longer recommended, and we are using risk group as in patient who has prior respiratory isolates of MRSA, Pseudomonas, or they are previously admitted in the last 90 days with use of parenteral antibiotics. Routine follow-up checks X-ray after the treatment of pneumonia are not recommended, but however, in patients with high suspicions of other alternative diagnoses such as malignancy, interstitial pneumonia, we can actually perform a repeated chest X-ray or other imaging modules as clinically indicated. So that's all of my presentations. Here are my references, and I hope everybody enjoyed the virtual CME. Thank you.